The treatment options of endometriosis are limited because in most of cases the cause is uncertain. Conservative management includes simple analgesia or hormonal drugs to suppress ovarian function like progestogens, the levonorgestrel intrauterine system, gonadotropin-releasing hormone agonists. Surgical management includes ablation or excision of endometriotic lesions. Women may require multiple admissions for surgery and prolonged treatment with costly drugs that can have problematic side effects. Surgical planning needs to be aware of the proximity of the disease to the ureter and the risk of ureteric stricture leading to hydronephrosis and renal dysfunction. The surgical risks include damage to the bowel, bladder, and ureters. The risks are increased if deep endometriosis is present secondary to anatomical displacement of structures such as the ureter, as well as in repeat surgical cases where repeated ureterolysis can increase the risk of ureteral ischemia, and repeated bowel shavings can reduce the integrity of the bowel wall, increasing the risk of fistula formation. Bowel resection or injury increases the risk of fecal peritonitis. Consideration should be given to ureteral stent insertion in cases of bladder endometriosis close to the trigone. The stent can usually be removed after approximately 6 weeks. A catheter will be needed for 8 to 10 days postoperatively, followed by a cystogram checking for suture integrity prior to removal. Rarely, infection in an endometrioma will result in the formation of a tubo-ovarian abscess. For a woman who has completed her family hysterectomy plus bilateral salpingo-oophorectomy with total excision of endometriotic disease offers a good chance of cure. Surgical treatment, however, in a woman who wishes to retain her fertility needs to be as conservative as possible. The aim is to remove the endometriotic tissue while restoring the pelvic anatomy. The preferential method to retain ovarian function is ovarian drainage, with directed spot ablation like electrocoagulation, thermal coagulation, laser, or plasma energy. Counseling needs to include the increased risk of recurrence with cyst drainage versus a cystectomy, as well as consideration for preoperative oocyte cryopreservation, especially in the presence of bilateral ovarian disease. Furthermore, bowel shaving versus bowel resection is associated with the risk of incomplete disease resection.